Welcome to my Health Informatics Process Map assignment. The process maps in this assignment will be based around the framework shown in this slide. This framework is Gillespie and Patterson's Situated Clinical Decision-Making Framework. The first process map in this assignment will be broad and will touch on the context of Edith's case, the ways of knowing, shown in this diagram, and the cues, judgments, decisions, and evaluations needed to care for Edith and how they interrelate. There will be more specific concept maps later analyzing the cues needed to be collected, the judgments made, the decisions, the actions, and the evaluations of things more specific to Edith's case. This process map broadly outlines the steps needed to care for Edith in the most effective way possible. You need to have knowledge of the context, like where you'll be working. For example, you need to know the policies and procedures that are usually followed, the different kinds of cases that arrive on the ward. You need to know the surgery, what an ORIF surgery is, and the usual assessments that need to be done post-op that will also need to be done on Edith. And you need to know information about Edith, such as her age and different risk factors for different complications. When she arrives back to the ward, you need to collect any cues. Then you need to make judgments from these cues of what care she needs. You then need to form decisions and make actions about what you're going to do. And then you need to evaluate if these actions and decisions have worked or if you have to change your thinking to provide better care for Edith. The cues, judgments, decisions, actions, and evaluations will be analyzed further and more specifically to Edith's case in the later process maps. The process for vital signs and primary assessment are very similar. Both assessments also provide key information on the current status of Edith. This is why I would conduct these assessments first, to get a baseline. With both processes, if Edith's data has no abnormalities, then no prompt action is required, and I would just reassess later to see if anything changes or if Edith deteriorates. If something abnormal turns up in the vital signs or primary assessment, my decision is to pinpoint the issue, notify the doctor, and implement interventions to correct this. If the issue is life-threatening, I would call a code blue. If the abnormal assessment results remain or worsen, I will reevaluate and choose a different intervention, then evaluate its success. If the issue found is rectified, then I would reassess as often as required. The process of pain management closely matches the last two processes, in that cues are collected from Edith, judgments are made, pain or no pain, and decisions are made. No pain relief or pain relief is required. If there is no pain relief required, then I would simply reevaluate on a regular basis. If Edith is in pain and is in need of pain relief, I would go and see if she has any allergies and see the PRN medications that she's been prescribed. I would determine the best pain relief method using the attached analgesic ladder. Then, like the other processes, I would evaluate if her pain reduced or stopped, or if it has gotten worse, in which case I would contact the doctor and reevaluate her pain relief need using the analgesic ladder again. The processes for determining and acting on Edith's risk for falls, deep vein thrombosis, and pressure ulcers are very similar. Most of the information for these assessments can be found before the patient arrives on the ward. So I personally would be starting to determine Edith's need for interventions before she arrives. More detail can be added once she arrives to get more accuracy. If not completed before Edith's submission, these processes will have to be done after the others already discussed. The processes all begin with finding Edith's risk factors. These are then put into the respective assessment charts found on the ward. I determined Edith to be at risk of falls, DVT, and pressure injuries, so I would then decide on prevention strategies to try and lower her risk of acquiring any of these complications. The evaluation is based on whether the prevention strategies prevented the complication or not. If yes, I would keep doing the same thing and reassessing Edith's condition over time. If not, I would have to treat the complication and change my intervention strategies to prevent it happening again. All of the processes described in this assignment are crucial in my care for Edith, and all follow the base process of collecting information, making judgments based on the information, making decisions of my care to promote Edith's help, acting on these decisions, and evaluating if they worked or not, keeping what worked and changing what didn't work. Thank you for listening.